Hello everyone, today we'll be discussing acute pancreatitis. Acute pancreatitis involves acute inflammation of the pancreas. Severity of acute pancreatitis varies widely, that is from mild conditions that only need conservative treatment to severe and complicated diseases that have high morbidity and mortality. The mortality of acute pancreatitis ranges from 3% in patients with mild edematous pancreatitis to as high as 20% in patients with pancreatic necrosis. Diagnosis of acute presentation is simple, but the major challenge is predicting the progression of the disease course and outcome. So, the duration of the disease is essential in determining the level of care. So, basically, what they're telling you is diagnosis of acute pancreatitis is quite easy. However, what the major challenge is predicting the course of the disease. How is it going to progress? We'll discuss that in the slides that are coming up. So, a little bit on the anatomy. So, the pancreas is a digestive gland organ and is found in front of the bodies of vertebra L1 and L2 on the posterior abdominal wall. The pancreas lies between the duodenum on the right and the spleen on the left transversely. It is divided into four parts, which is the head, neck, body, and tail. The primary function of the pancreas can be divided into exocrine and endocrine functions. So the exocrine secretion, which is pancreatic juice from the acinar cells, enters the duodenum through the main and accessory pancreatic ducts, and endocrine secretions, glucagon and insulin from the pancreatic islets of Langerhans enter the blood. So we have the Atlanta classification that broadly classifies acute pancreatitis into two categories. These are interstitial edematous acute pancreatitis, which is characterized by the acute inflammation of the pancreatic parenchyma and surrounding peripancreatic tissue. Then there is necrotizing acute pancreatitis, which is characterized by necrosis of pancreatic parenchyma and peripancreatic tissue. Then, based on the severity of the disease, acute pancreatitis is divided into the following types. In mild acute pancreatitis, there is the absence of local or systemic complications and organ failure. In moderately severe acute pancreatitis, there are local complications with or without organic failure for less than 48 hours. Then, in severe acute pancreatitis, there is persistent organ failure for more than 48 hours with the involvement of one or more than one organs. Pathophysiology. So the pathophysiology of acute pancreatitis is based on the premature activation of the enzymes zymogen and trypsinogen. So this results in local pancreatic destruction and activation of the inflammatory cascade. So this inflammatory cascade is the one that causes the systemic inflammatory response syndrome that is often associated with acute pancreatitis. Then this systemic inflammation can lead to multi-organ dysfunction syndrome. So the causes of pancreatitis include, so the most common causes are gallstones, alcohol use, and hypertriglyceridemia. Then the rate of occurrence of each etiology of acute pancreatitis varies across geographic regions and socioeconomic strata. So common etiologies of acute pancreatitis are listed below. So they're divided into mechanical, toxic, and metabolic and others. Under mechanical, we've got gallstones, pancreatic duct obstruction, dysfunction of the sphincter of Oddi, trauma, ampullary obstruction, and congenital malformations, such as an annular pancreas. Then toxic and metabolic causes include alcohol, hyperlipidemias, drugs, scorpion venom, organophosphorus poisoning, hypercalcemia. Then other causes include ischemia, iatrogenic injury, such as during a procedure called ERCP, infection, hereditary causes autoimmune and cystic fibrosis. So this is just a mnemonic to remember the causes of acute pancreatitis as get smashed pin. Clinical features. So generally acute pancreatitis will present with moderate to severe abdominal pain, which is commonly in the epigastrium, radiates to the back, and is associated with nausea and anorexia. On physical exam, which is usually significant for fever, tachycardia, and in some patients, hypotension. The abdominal exam will typically reveal epigastric tenderness with possible guiding, rigidity, and decreased bowel sounds. Then, in extreme cases where retroperitoneal bleeding has occurred, you'll see the gray Turner sign, which presents as ecchymosis on the flanks. Then, in contrast, they may also present with Cullen sign, which appears as periumbilical ecchymosis that is secondary to peritoneal hemorrhage. So a summary of the above. So in patients with acute pancreatitis, on history, you'd like to know about any history of gallstone disease, alcohol abuse, the medications they use, history of any weight loss, any history of new onset of diabetes, any previous surgeries of or trauma, hypertriglyceridemia or hypercalcemia, any autoimmune disease, and you need to ask for any genetic causes. Then on examination, you will notice fever, tachycardia, epigastric tenderness or palpable mass in the epigastric area. Assess for jaundice, check for the Cullen sign and gray Turner sign. Then on lab investigations, you will notice there will be elevated serum amylase and lipase levels 3 to 5 times of normal. There will be elevated white blood cell count, elevated serum triglycerides, low calcium, elevated serum bilirubin, AST, ALT, LDH, and alkaline phosphatase. On the imaging, you perform a chest and abdominal X-ray, abdominal ultrasound scan, and a CT of the abdomen. On serological tests, you can do IgG4. So for diagnosis of acute pancreatitis, you use the revised Atlanta criteria, which defines the diagnosis of acute pancreatitis. This states that acute pancreatitis requires at least 2 of the following 3 criteria, which are 1. Lipase or amylase levels 3 times the upper limit of normal. 2. Physical exam consistent with pancreatitis. 3. Imaging, which is CT, MRI, or ultrasound findings that are consistent with acute pancreatitis. Then treatment or management of acute pancreatitis. So you start with early aggressive fluid resuscitation. That's the foundation of management of acute pancreatitis. So the choice of fluid is Ringer's lactate, which is given with an initial bolus of 15 to 20 ml per kg, and followed by administering at a rate of 3 ml per kg per hour, approximately 250 to 500 ml per hour in the first 24 hours, if there are no other contraindications for fluid. The fluid resuscitation monitoring is done with a combination of labs, blood urea nitrogen, hematocrit, and urine output every 4 to 6 hours in the first 24 hours of resuscitation. Then no response to initial fluid resuscitation indicates a high likelihood of ensuing multiple organ dysfunction syndrome and is grounds for upgrading the level of care. Another critical issue in managing acute pancreatitis is nutrition. So initially the commonly employed practice was to keep NPO, which is nil per oral, until abdominal pain, vomiting, nausea, loss of appetite, and ileus improves. However, recent studies support early feeding in mild pancreatitis and consider it safe as it does not exacerbate the symptoms. Usually prophylactic antibiotics are not needed. Pain management is a critical priority in treating acute pancreatitis, and nearly all patients presenting with acute pancreatitis experience abdominal pain at some point during the disease. So how do you manage pain? So it includes the use of NSAIDs and highly potent opioid analgesics in an escalating manner, along with other interventional strategies. Complications of pancreatitis. So local complications of acute pancreatitis include early, which is less than 4 weeks, peripancreatic fluid collection, and pancreatic or peripancreatic necrosis. And late, which is more than 4 weeks, you can develop a pancreatic pseudocyst and walled-off necrosis. So of note is usually peripancreatic fluid collection resolves spontaneously in most cases, and only less than 10% results in pancreatic pseudocyst. So that's all about acute pancreatitis. If you like the video, please like, subscribe, and comment. Thank you.